Welcome to the Explainer, everyone. Now, if you've ever, just briefly glanced at a medical textbook detailing conditions of the ear, nose, and throat, you already know that the sheer volume of eponymous syndromes, it can feel completely overwhelming. I mean, it's a lot. But today, our goal is to take this massive, honestly kind of chaotic list of head and neck syndromes and turn it into a fascinating, logical tour. We're going to decode the chaos by looking at the human body exactly the way a master clinician does, through the incredibly powerful lens of pattern recognition. And that begs the central question we're tackling today, right? How on earth do medical professionals actually make sense of dozens of complex head and neck syndromes without their heads exploding? Well, the secret isn't a photographic memory. It's really the ability to untangle this vast web of medical data by looking for very precise overlapping clinical patterns. Because symptoms, they rarely just happen in total isolation. They're basically breadcrumbs, leading us to a much larger interconnected truth about a patient's anatomy. Okay, let's dive into this. Here is our roadmap for today. We'll cover 1. The ear and hearing loss, 2. Craniofacial and nerve anomalies, 3. Airway and throat obstructions, and finally 4. Systemic and genetic connections. Now, what's really interesting about this distribution is the heavy hitters. When we categorize this whole extensive list, we see a massive 30% are anchored specifically by ear and hearing loss issues, while another 25% are rooted in systemic and genetic connections. It's kind of wild to think about, but the ear is so often the literal canary in the coal mine for much broader bodily syndromes. So, moving into Section 1, the ear and hearing loss, decoding audiovestibular signals. Let's play a quick game of clinical deduction. Imagine a patient comes into your clinic. What underlying condition links episodic vertigo, fluctuating hearing loss, a constant ringing, tinnitus, and this weird sensation of oral fullness in the ear? Individually, sure, these symptoms could mean a dozen different things, but together, they perfectly define Meniere's disease syndrome. When a physician sees these 4 highly specific traits combine, they immediately recognize the classic pattern. It's just a brilliant example of how individual, somewhat common complaints can actually merge into a definitive, incredibly recognizable syndrome. And this brilliantly illustrates how we categorize far beyond the ear itself. Look, all 3 of these syndromes feature hearing loss, right? But doctors differentiate them by hunting for secondary clues. Like with Usher syndrome, that sensory neural hearing loss is paired with progressive retinitis pigmentosa, so vision loss. In Pendred syndrome, the hearing loss is linked to thyroid disease and an enlarged vestibular aqueduct. And then in Alport syndrome, the hearing loss is tied to hereditary nephropathy, which means kidney disease. So the ear points to the problem, but the secondary organs, they confirm the whole shebang. The variations here can be honestly striking. Take Waardenburg syndrome. The hearing loss there is genetically linked with a distinct white forelock of hair, or sometimes these piercing bright blue eyes. But then you have Jervell and Long-Nielsen syndrome, where congenital deafness is associated with something entirely invisible, a prolonged QT interval. That's an electrical defect of the heart. So the clue is in the ear, but the actual threat is a potentially fatal cardiac rhythm. Crazy, right? Okay, moving right along to Section 2, craniofacial and nerve anomalies, the structure and the spark. It's absolutely crucial to remember that the architecture of the human face is incredibly complex, and because of that, it's highly susceptible to disruption. These facial syndromes, they aren't just cosmetic variations. They represent really deep structural anomalies or even profound paralytic conditions that fundamentally alter how a person interacts with the world around them. Now, a really critical distinction to make here is congenital versus acquired. Basically, is the syndrome born or is it made? Apert syndrome is a great example of congenital. It's craniosynostosis, meaning the skull bones fuse way too early, leading to midface hypoplasia and significant airway problems. Fraze syndrome, on the other hand, is entirely acquired. It manifests as gustatory sweating. Literally, a patient sweats while they are eating. But this only happens after a surgery or injury causes the facial nerves to sort of cross-wire and regenerate incorrectly. The body's wiring literally gets confused. We can apply that exact same pattern recognition to facial paralysis. Think about it. If a patient can't move their face, why? Well, Mobius syndrome gives us congenital facial and abducens nerve palsy, meaning they are born without that movement. Ramsay-Hunt syndrome, though, that's a viral attack. It's herpes zoster oticus, causing facial paralysis along with pretty severe ear symptoms. And then there's Melkerson-Rosenthal syndrome. This one is a really unique inflammatory condition characterized by recurrent facial paralysis, but it's paired with facial edema and a fissured tongue. The overarching symptom is paralysis, sure, but the patterns, they tell three completely different stories. Then we have these incredibly striking progressive conditions like Perry-Romberg syndrome. This one is defined by progressive hemifacial atrophy. Literally, the soft tissues on just one side of the face progressively waste away over time. Recognizing a unique clinical presentation like this early on is absolutely vital, and it just reinforces why understanding these specific architectural syndromes is so incredibly important. Which brings us to Section 3, Airway and Throat Obstructions, Life, Death, and Anatomy. Let me be perfectly clear here. Obstructions in the head and neck, these are high-stakes, life-or-death clinical emergencies. When we talk about syndromes affecting the airway, we are talking about the immediate preservation of life. Just a few millimeters of structural difference in this area literally changes everything. You see, severe jaw and facial bone abnormalities directly lead to these dangerous airway blockages. Take Pierre-Robin sequence, for example. A very small lower jaw causes the tongue to actually fall backward, and that combination creates an immediate, incredibly severe airway obstruction. Similarly, Treacher-Collins syndrome involves the underdevelopment of the facial bones, leading to compounded airway issues plus hearing loss. In these cases, the physical structure directly threatens the airway. But here's the crucial point. A threat to the neck's anatomy isn't always a bone deformity. Consider Lemire syndrome. Now, this begins as a standard oropharyngeal infection, just a simple sore throat, but it dangerously escalates into septic thrombophlebitis of the internal jugular vein. Basically, a massive infected clot forms right in the major vein of the neck. It's a terrifying chain reaction, and it really proves just how delicate the throat's anatomy truly is. All right, so we've looked at the ear, the face, and the airway. We've seen how localized anatomy can go terribly wrong. But as we transition into the final phase of this explainer, we really have to acknowledge a much broader medical truth. These localized issues in the head and neck, they are rarely just about the ear, nose, and throat. That brings us to Section 4, Systemic and Genetic Connections. The body is a web. There is honestly no better example of this web than CHARGE syndrome. The acronym pretty much lays it all out for us. You've got coloboma of the eye, heart defects, choanal which blocks the nasal airway, growth retardation, genital anomalies, and finally, ear abnormalities. Now, an ENT doctor might be called in to just fix the nasal airway or look at the ear, but they're actually treating a patient whose entire systemic web has been fundamentally altered. The sheer scale of these linkages is frankly mind-blowing. Like in Carter-Jenner syndrome, a patient has chronic sinus and lung issues, but incredibly, they also have situs inversus. Their internal organs are literally mirrored, sitting on the complete opposite side of their body. No way, right? Then you have Cogan syndrome, which pairs inner ear vertigo with severe eye inflammation. And Osler-Weber-Rendu syndrome, that often just presents as simple nosebleeds, but it's actually driven by widened blood vessels throughout the entire body. And sometimes the immune system itself attacks the ENT regions. We see these very distinct autoimmune and inflammatory overlaps. Sjogren syndrome is a prime example here, where autoimmune destruction specifically targets the salivary and lacrimal glands. That causes severely dry mouth and eyes. Or consider the highly specific pattern of Samter triad. In this one, a patient presents with asthma, nasal polyps, and a really severe sensitivity to aspirin. These are definitely not random coincidences. They are distinct, recognizable patterns of inflammation just cascading through the body. And that brings us right back to our starting thesis, doesn't it? Pattern recognition is the absolute key to mastering these complex anatomical syndromes. By taking 40 seemingly random medical conditions and organizing them thematically, by sensory loss, structural facial defects, airway threats, and these systemic genetic webs, diagnosis doesn't just become possible, it becomes profoundly logical. It really changes how you look at the human body, for sure. So I want to leave you with this final thought. The next time someone mentions a simple earache, a bout of dizziness, or a recurring nasal polyp, you kind of have to ask yourself, are we really looking closely enough at the rest of the body's patterns? Because, as we've seen today in this explainer, in the incredibly complex world of human anatomy, nothing is ever truly isolated. Thanks for joining me, and hey, keep looking for those patterns.